Thank you. Good morning. It's a great pleasure to be back in Saskatoon. Many friends in the room. When I'm in Paris, I could say, well, this is the first city where I fall in love here. When I'm here thanks to Greg Marshalden and to Romano, I could say this is the city where my hair turned gray. So what I will present this morning, I'm pretty sure in most cases for you it's common knowledge, so I will try to go relatively quickly, especially at the beginning, so that we have time first for the two excellent papers that my colleagues will present, but also for questions. Let's start by this idea that is certainly not new, and the notion that health in our country is a shared responsibility between the federal government and the provinces. And it's probably not true since time immemorial, but it's certainly true since the Constitution Act of 1867. You have, certainly all of you, because it's in all textbooks, repeated by ministers of health repeatedly, and this notion that, yeah, there is a section of the Constitution Act, 92(7), that gives provinces power over essentially health organizations, health institutions, hospitals. Most people forget that at the very beginning, in a very symmetric way, the same Constitution was giving jurisdiction to the federal government over public health. And a very interesting question, we don't have the time to discuss those issues this morning, but a very interesting question is why the federal government has not developed its responsibilities over public health in the same aggressive way provinces have done in the healthcare delivery area. And another aspect of that shared responsibility is clearly the Medicare Compact, this very complex social construction that has taken place after the Hospital Insurance Act in 1957, and I think has found its apex with the Canada Health Act in 1984. Again, this is something in which we have consecrated a role for the federal government as a funder, but also as a guarantor of the healthcare system of the country. And that has involved not only governments, but all sorts of actors, the docs first, but physicians, nurses, hospitals, and so on and so forth. I decided to mention here the Lalonde report, and I was very happy to hear Dennis in the previous session mentioning the question of determinants of health. So we all know that the Lalonde report is the first time a government was actually using the language of determinants of health. But you have to know that when the report was developed in the 1970s, it was developed in the context of a reflection on the future role of the federal government. And because people were realizing at the time that most of those determinants were actually under federal jurisdiction, and that you cannot be serious about the determinants of health in this country if you don't at the same time recognize that the federal government has a role. If health is more than health care, then the federal government has a massive, important determinant role in health. And finally, I think it's important to reflect on the role the courts have taken. Picard has written a paper in the Globe, I think was yesterday, about this, so you have all this very fresh to your memory, but it's very clear that courts are playing a much more important role now than they have played in the past. They are constantly reminding the major stakeholders that there is a shared responsibility for the federal government and the provinces in health. And I think we have to pay much more attention to the courts that we have in the past. And I'm talking here to people that have an interest in a scholarly interest in the evolution of health law. Just as a small parenthesis, but the decision that has been rendered by the Supreme Court of the US, for instance, on the ACA recently, you probably have noticed, but the answer to the fourth question, the question about the expansion of Medicaid, is that the majority opinion is based on a reflection on the limitation to the spending power of the federal government. You know, we need to pay attention to those decisions because they will have an impact on what is going on here in Canada. But I have here two quotes from the Chief Justice, the current Chief Justice of Canada, and I think they are quite clear. This is a quote that comes from the decision, very famous decision on Insight last year. Insight is the safe injection site in Vancouver, sorry. The federal role in the domain of health makes it impossible to precisely define what falls in or out the proposed provincial core. Overlapping federal jurisdiction and the sheer size and diversity of provincial health power render daunting the task of drawing a bright line around a protected provincial core of health where federal legislation may not tread. And a year before, in the reference on assisted reproduction, in a much more concise way, the same Chief Justice, Beverly McLaughlin, wrote, "Health is the jurisdiction shared by both the provinces and the federal government." I don't think you can be clearer than this. This was a very, and I talk of the system that has built over the year, was a quite viable arrangement. First, it was very clear supply was largely a provincial matter, and this is good. You know, again, if we're serious about our preoccupation for the responsiveness of health system, it's a good thing that provinces are developing health delivery systems that are attuned to the values, to the culture, to the legal tradition of the provinces. This is a very good arrangement. On the other hand, for the reasons I just discussed, the federal government had an influence on demand, an influence through the CHA or the Medicare Compact, if you prefer, because in a way it was entitling Canadians to the free access to medical and hospital care, but also because it has an influence on the determinants of health. And when the federal government makes decision in economic policy or decision on immigration, it has a direct impact on the way care will be provided, and certainly on the costs that will be faced by the system. The fact that supply and demand was not controlled by the same actors were forcing both levels to cooperate. And this is really a particularity of the Canadian system. I don't know other examples of this in the world in which you have forced cooperation between the two levels, because it's very difficult to reform a system if you don't control supply and demand. And the only way to do it in our country was to have the two governments sitting together at the same table and making co-decisions about the future of the system. It was interesting as well because it was giving our system the benefits of asymmetry, the capacity for each province to develop its own health system, but also of centralization because of the existence of those national norms, national standards, and agreement between the different players. So the question now, I think, on the mind of many people is this all going to change, given the new orientations that have been taken by the current government of Canada? I had friends, I remember in the spring, coming to see me in Montreal. I'm the Yoda of health policy because of my poor grammar. So they come to see me and they ask me questions about the current situation, saying, is the system going to collapse? And my answer is we're certainly not there yet. What is changing, and changing fast, is the governing structure of the health system. Here I've put together, this is something that some of you that have heard me speak in the past may have seen in other presentations. Those are like 4 ideal types of way of governing our health system. And the national health system has never really been a reality, but it has certainly been part of the conversation about the future of the system. And I could quote you papers that have been written by very eminent health policy specialists in the country that have argued in favor of a national health service. One of my colleagues has said that if we were to write the Constitution today, we will give the federal government responsibility over healthcare because it's so important as an area of public policy. The steady state of the system for more than 40 years has certainly been the primus inter pares system, in which the federal government acts as a senior government. This is why the federal government is co-chairing every single committee or panel. This is why the federal government is funding most of those activities, with the idea that he's part of the game, but he's also playing a very important and senior role in the system. And I haven't checked recently, but that was the like the official blurb when you were going on the website of Health Canada about the future of the system. I think that after Flaherty's announcement last December, the government has moved in a different place, which I have called here one among many. And I take that from the speeches that have been made by the Federal Minister of Health. The idea is that the justification for the federal government now to participate in conversations about the future of healthcare is mostly because, as they say, we are the fourth or the fifth provider, maybe the sixth tomorrow, but we are the fourth or the fifth provider in the country, and therefore we have the right to have a seat at the table, and we would like to contribute to the conversation. What makes it complicated is that I think the government is not satisfied with that position and that the system is still evolving toward what I have called here, because this is their own language, real accountability. And I'm thinking of speeches that have been given by Minister Bernier 2 years ago, a famous paper by Ken Busenkool that have been much discussed last year, in which they have used that very language, the idea that there will be only real accountability in this country when taxation and the delivery of service will be completely aligned, and this means a complete retreat of from the federal government from the healthcare sector. So, will we see the system collapse with this very significant transformation of the governance structure of the system? Well, there are a few lessons from the field of studies on federalism that could help us think about this. It's clear, for instance, this is the iron law of federalism, that there will be more competition in the system, and that there will be more competition in part because there is no senior government to force people to cooperate. And this is known from everybody that has worked on federation in the past. This competition could be creative, but in most cases, it will be rather to say, let's have the lower taxes and therefore let's cut services to make sure that we keep our taxes low. And this is a very dangerous spiral for the system. It's clear, and this is also part of the public discourse at this moment, you all know that there will be less sharing and less redistribution. The federal presence in the system was creating a larger pool in terms of health insurance in the country. The less you will have of that, the more you will have equalization based on demography, the less you will see that kind of sharing taking place. And the provinces have not been very good at borrowing from other provinces' solutions without the federal government intervening and imposing that solution to others. And it's the same in the United States, and therefore it is not due to a lack of leadership, it's due to the structure of federalism itself that produces that kind of results. We may see more rigidity and conservatism, and what we have learned in the 1990s during the period where there was those massive cuts in transfers is that the perspective on health and healthcare tend to narrow in period of crisis, in period where there is less resources available. Public health has suffered a lot during those years, and we could very easily go in a situation that will just be a replication of that period. I don't want to end on something that is negative, and so there is also opportunities in the current situation, and I think we have to look at those opportunities. The first thing that we need to recognize is that the health system of Canada is a very large, complex system in which adjustments take place not because of the intervention of politicians, and those adjustments will continue to take place. This is in large part a knowledge and science-driven system, so science and knowledge will continue to play a role in the way the system adjusts itself without the politicians paying any attention to those adjustments, and this has taken place in the past and will continue at least for the foreseeable future. There is also room now for experimentation and innovation, and I know that those words are loaded, that people think, oh my God, experimentation in healthcare, that means by definition privatization. Not necessarily. At least at this moment, we're not obliged to wait for every single province and territory to join before trying to do things. There is no reasons why there is not a drug agency for the Atlantic. Give me one reason. No, the 4 provinces could very easily put their resources together and they don't have to wait for Ottawa to do these things. And room exists at this moment to do this, and I think we have to push very hard on the provinces that they use the room that has been opened for them to do those kind of positive experimentation. When we look at the Council of the Federation, and its evolution in the last 2-3 years, we see also that they are discovering that there is profit in cooperation. Not all the time, but sometimes. And I think we shouldn't be just saying, well, this is not interesting. No, that's not true. Look carefully at the reports they have released. Yes, there is a lot of trivial things in this, but there are a lot of trivial things in what we publish, So I think I look at what the Council of the Federation is doing, and I say, well, if this could be an incentive for collaboration to develop and sustain a national dimension in the system, why not? And finally, and that will be my last remark, I think that I'm very much encouraged, and most of my research interest in the next couple of years will go in that direction, is the fact that we see completely new structure emerging in the system. There has always been in the health system of Canada a thick web of organization in between the federal government per se and the provinces. And most of the national norms and standards were basically issued by this group of organizations. I'm thinking Royal Colleges, CMA, CNA, and the agencies that have been created since then. What we see now is the emergence of completely new structure. I'm thinking cancer care, or the Partnership Over Cancer, for instance, where you're seeing at the table NGOs, private sector, governments, all working together, all defining standards and norms in terms of transforming the practice, improving quality in the system. The CIHR-EHSPR has just recently launched an initiative to have all the stakeholders of the health system, including governments, to start sharing their publications. The response has been immediate. Everybody's at the table. Everybody's agreeable to play. And when you see the province of Quebec, I don't know if it will stay like this, but this is another question, but at least the government of Quebec sitting at the table and accepting to share information without asking questions about jurisdiction and federal intrusion and so on and so forth, I think there is hope, and I think, therefore, there is hope for us all. Thank you very much.